All right, I'm going to get started, everybody. Well, we'll see how many people come in. We're at 175 right now. All right, so welcome to the third day of the annual Disability Statistics Conference. This session today will be the impact of COVID, the COVID pandemic on people with disabilities. Data is pretty scarce, I should say, it's particularly with regard to people with disabilities. During this pandemic time, a lot of the traditional data sources are annual, and it takes them a while to get into the field, to be cleaned and processed. There are very few monthly or weekly or daily sources of information about people with disabilities. I'm going to just go ahead and start the upfront logistical things. Just some Zoom tips. You can select the speakers that you use if you go to the up arrow next to the audio settings and select the speakers that you use. You can also click on closed caption to get the subtitles from CART that we'll be using. You can also spotlight we have spotlighted the ASL interpreters today for accessibility best practices, so they'll stay at the top of the screen. On your computer, you can also look at multiple speakers by going to options and viewing the side-by-side or in gallery mode. There are various modes that you can see. Today's webinar is being recorded. We will post it later on the disabilitycompendium.org. It does say it takes some processing time. Hopefully we'll have them up in the next couple of days. This website is also where you can find all the materials that we talked about on the first day, the compendium, the annual report. You'll also be able to find the slides for each day, as well as the speaker bios and the recordings and everything. You can see last year's now if you want, but we will be posting those all at some point in the near future. As an attendee, you're just a viewer. You can ask questions in the Q&A box. The chat function has been disabled, although we can send out chats as panelists. There's some information about where to get the materials and where to do certain things in the chat area. But pay attention to the Q&A box, in particular the answered question. There are a lot of questions that come in during the webcast that we answer, but we also have a Q&A session at the end. And if everything goes accordingly, we should have about 15 minutes to do some open Q&A. If you have any questions, you can follow up after the webinar. You can email us at disability.statistics@unh.edu or just waiting for ASL. All right, or you can call us at 866-538-9521 for more information. All right, today's speakers, I'm going to turn it over to Amanda Reichard from NIDILRR to introduce today's speaker, and also Amanda will be doing help facilitating the Q&A at the end. Go ahead, take it away, Amanda.
Thanks, Andrew. Good afternoon if you're in the East Coast, and good morning if you're not. Welcome to the talk today. As Andrew said, one important highlight that's arisen from the COVID pandemic is the important need of data related to people with disabilities and how the current gaps have prevented us from being able to provide an evidence base for making policy decisions, such as whether people with IDD should be considered and at the highest risk level. So if there is a silver lining to the pandemic, that would be one of them, that this has created some momentum for improving data, especially for people with IDD. And another way that hopefully will dovetail with this and continue that momentum is the President's executive order on health equity for people with for vulnerable populations, in which he specifically names the disability population, which is a new, really new for something that high level to be specifying disability as a demographic variable. So there's a lot of momentum in this going on around this with the COVID pandemic. So that's very exciting. And maybe by this time next year, Andrew will we'll have some better data. Who knows?
Yeah.
Stay tuned. I'd like to introduce our speakers. I'm going to introduce them all at the same time rather than one at a time. And then we'll have some time for questions and answers at the end of the talks. So first, we have Dr. Allison Kolbe. She is at the Office of Science and Data Policy in the Department of Health and Human Services, Office of the Assistant Secretary for Planning and Evaluation, or ASPE. She applies data science techniques to health policy research, and she has a specific interest in social determinants of health and COVID-19 outcomes. Today, she'll be talking about the intersection of race, disability, and COVID-19 using machine learning approach. Next will be Dr. Kim Phillips. She is a research assistant professor at the Institute on Disability at the University of New Hampshire, where she leads and co-leads several grants related to disability data. She will draw upon her work as the primary investigator for the CDC-funded New Hampshire Disability and Health Project, among other work, to discuss using telehealth during the pandemic. Next will be Dr. Debra Brucker. She is a research associate professor at the Institute on Disability at the University of New Hampshire, and she will draw upon her extensive experience of applied policy research to discuss food sufficiency during COVID. And last but not least, we will have Dr. Shreya Paul and Dr. Andrew Houtenville talking about both from the IOD. Dr. Paul is a project director at UNH, and as I'm sure you know, Andrew is an associate professor of economics and research director at the IOD at UNH. What are you holding up there, Andrew?
Just my arms, just cheering for myself. Sorry.
Oh, okay. And he's the primary investigator of the RRTC that funds this event. Dr. Paul and Dr. Houtenville will use their combined expertise and experience to discuss the employment trends and state patterns during COVID. And I will turn it over to Dr. Kolbe.
Thank you, Amanda. Let me get my screen going here. Okay, should all be able to see my screen, so please holler if you can't. Thank you for the invitation to speak today. I'm really excited to share my work. As Amanda noted, I'm going to be talking today about my work on racial and ethnic disparities in COVID-19 and how disability plays into that as well, using a machine learning approach. So to start out with some background, as I'm sure many of you are aware, racial and ethnic minorities are experiencing higher rates of COVID-19 infection, hospitalization, and death. This figure here from the COVID tracking project, I think illustrates this pretty clearly, that there's a number of minority groups that have much higher death rates compared to the white population. I'm going to be focusing today specifically on the Black and African American population. We've also seen some reports that people with disabilities have a higher risk of infection and death, but as we've already heard today, there's relatively little data on this. This isn't something that's widely reported with the case data or death data that's coming out, so there's a lot of holes and questions that still need to be addressed related to this issue. So my project today that I'm going to be talking about is using machine learning to try to fill in some of the data gaps that we have. In particular, I'm going to be talking about disparities in death rates for Black and African American populations, and how we can use machine learning to predict the factors that are related to disparities, and how we can also make predictions about where disparities are occurring where we don't have data. So I was doing this at the county level, so I first needed to define a set of county level characteristics that I could use to potentially predict disparities in COVID-19 death rates. So what I have here on this slide are some examples of these. These fall into kind of some general buckets. This isn't the entire list, but this gives you kind of a general idea of the types of variables I was working with. So I have some socio-demographic data, things like income, education, employment. I have data related to health, prevalence of chronic conditions and health behaviors, among other things. Variables related to healthcare access, such as insurance coverage, access to doctors or hospital resources, things related to the physical environment, such as pollution, population density, as well as the presence of food deserts in a given area. And finally, variables related to COVID-19, including things like COVID-19 testing, how accessible is it, what are the local policies related to COVID-19, so things like mask mandates, stay-at-home orders, as well as cell phone mobility data that can kind of show in a given county how people are actually changing their behaviors. So using all of these different types of variables, I then wanted to predict disparities, which in this case I'm defining as a death rate for the Black population that's significantly higher than the death rate for a white population in a given county. So to briefly describe the model that I was using to do this, I used supervised machine learning, an algorithm called random forest, to classify counties into high and low disparity groups. Without going into a whole lot of detail about this, random forest was a useful algorithm for this because it can evaluate more complex nonlinear relationships between many different variables. And as you might imagine, with these kinds of data sets, you're going to have a lot of potentially correlated variables. And random forest can handle that a little bit more robustly than some other methods. So in terms of the actual variables I was using, I had 66 county level descriptors that fell into those buckets I was describing earlier. So these are variables from a variety of federal and non-federal data sources like the American Community Survey, but also things like Google, cell phone data, that sort of thing. And then I was using CDC provisional death count data. I had 491 counties with data that had at least 50 deaths and at least 1% of these deaths in Black individuals. And this is essentially just to help us control for any strong outliers that might mess up our model. So this is the number of counties I had when I ran my model about 2 weeks ago. So first, let me show you how my model actually performs. So again, I had 491 counties, and this map here on the left is showing you what we actually know about where disparities are happening in death rates. So any county that's pictured here in red, there is a disparity in that county based on the death rate data that we have. Any in this cream yellowish color, there's not currently a disparity in that county. Anything in gray, we just don't have data. So there's obviously a lot of counties that we don't have data for in this. Over here on the right is where my model would predict disparities to occur based on all those variables that I was showing you earlier. So overall, my model is about 64% accurate. So this obviously has some room for improvement. And I think the more we refine the types of data that we put into the model, as well as the quality of the data that we're using to predict, it will definitely improve this number. So I'm constantly working on that. But importantly, this is better than a random guess. So we could use this to make actual, to perform some analysis to try to understand what's actually underlying some of these disparities that we're seeing. So again, a really key question I wanted to ask here was what factors are associated with disparities? So these here are my top 8 variables that came out. Again, I had 66 that went into this model. So this is kind of the top of the line here. And you can see just right off the top of the page here that there's a variety of different kind of categories these fall into. So this is not just there's not just one story here. So we have variables related to social vulnerability, variables related to health, healthcare access, as well as COVID-19. So a lot of interesting things going on, but there's a few I wanted to highlight in particular. So looking first, so these are the most significant variables that came out of my analysis. I had socioeconomic variables. So socioeconomic status and related variables is likely to be involved to some degree here. I don't think that's super surprising, but it's an interesting result. Again, we also have It's healthcare access issue. So this is the ICU beds per 100,000 residents. As you might imagine, the access to hospital resources might impact the outcomes that a person might experience. So I think this is an interesting variable that I'd really like to dig into a little bit further in terms of how it contributes to disparities. But I want to focus on these two variables right here, disability and obesity. So the variable I was using for disability is actually from the Social Vulnerability Index calculation. So this is a percentile. This is the percentile that the county is in terms of the percentage of people with disabilities in that county. And then this is the percentage of people with obesity in a given county. So it was pretty interesting that those two came out as sort of top variables in the top 4 out of 66 variables. And I think it's interesting in that we know that people with disabilities are at a greater risk of infection and death. We also know that obesity is a significant risk factor for worse COVID outcomes. But I think a really important takeaway here too is that these are variables that we know that there are disparities in as well. We know that there's some disproportionate impact on the Black community, both in terms of prevalence of disability and the prevalence of obesity. So I think as we look at this issue, obviously there's a lot of factors that are playing into it, but looking at some of these factors that have disparities in and of themselves are playing into the greater disparities that we're seeing in COVID-19 deaths. I think it's going to be a really important question moving forward. So finally, what I alluded to in the beginning was that we can use this type of a model to make predictions about where disparities are occurring. I showed you a bunch of maps that have a lot of gray in them. There's a lot of missing data. And this is a real problem for trying to figure out what's going on and where it's happening and where do we need to target resources. So if I took my actual data that I knew, and then I added in all of the other counties where we didn't have data and ran my model on those, I predicted another 725 counties with likely disparities. So I think this is pretty staggering. These are counties we don't really know what's going on there. They may not have a disparity right now, or may just not have the data yet to know if they have a disparity, but these are places where maybe there's going to be a disparity in the future and we need to be looking into that more closely. So I want to just leave that image up as I wrap up here. So I think this really drives home the point that there's a lot going on here that we just really don't have a handle on. I think my analysis showed you that disparities are driven by many different factors. There's a lot of things going on here, but looking specifically at other factors that have disparities in them, including disability and obesity, are really key in this. And I hope I also convinced you that machine learning is an approach that we can use to make predictions where data are limited. And I think this is something that could be potentially really useful in evaluating the impact on people with disabilities, where we, again, don't have much data. There's just not a lot of current and real-time data on what's happening in those communities. Machine learning is a way that we can try to do that, take the data that we have and make predictions about what we don't have. Finally, improvements in data reporting is really going to be the key here. The more data we have, the better we can make these predictions and the better we can target where interventions are needed. And so this is not limited just to racial and ethnic reporting, but also just in general, understanding risk factors for all sorts of diverse populations. Having the data is really key. So with that, I will wrap up, but thank you so much for your attention and listening to my presentation today. I look forward to your questions and feel free to reach out to me via email. My email is on the screen here. It's just my first and last name, allison.kolbe@hhs.gov. I look forward to hearing from you. And with that, I will pass it to Kim Phillips.
Before you start, Allison, there are a number of questions in the Q&A box. If you want to look at those while you're still on and potentially respond to them here, might stop someone from needing to email you later.
Sure.
Great, thanks. Take it away, Kim.
Thank you very much. Megan, you're going to share my slides? Yes, okay. So today I'll be talking about the telehealth experience of adults with and without disabilities during COVID-19. This is a study funded by NIDILRR as part of the Disability Statistics and Demographics RRTC. And I'd also like to acknowledge my colleague Kimara Nzamubona for his contributions to this work. Next slide. So of course, access to healthcare is essential for everyone. And we know that many barriers exist for people with disabilities in accessing high quality care. COVID-19 precipitated a pretty rapid switch to remote care, or what I'll refer to as telehealth. And the goal of this study is to make sure that people with disabilities aren't being left behind and in this rapid switch, and that they have equitable access to quality telehealth. Next slide. So the research questions for this study include: who is accessing telehealth? For which kinds of care? Is telehealth working for people with disabilities? And if not, what can be done to improve it? Next slide. To answer the research questions, we conducted an online survey using Qualtrics and an internet access panel. Respondents were 13,277 US adults, ages 18 to 64, who answered questions about their telehealth experiences in the previous 6 months, meaning the period from March to August of 2020. The survey included some original items, and I also want to note that the patient experience of care measure was informed by previous research conducted by Donnellan et al., 2019 American Journal of Managed Care. And so we computed frequency, not yet. We computed frequencies and chi-square tests of statistical significance, and we did logistic regressions, which is what I'll be reporting here. Mostly I'll be discussing the adjusted odds ratios. Next slide, please. So for some sample characteristics, we did establish quotas in order to ensure a range of representation and that the survey sample would be similar to the American Community Survey on some key socio-demographic variables, including age, race and ethnicity, gender, household income, and geographical region. Disability was measured using the 6-question sequence in the American Community Survey, which asks about difficulties with hearing, vision, walking and climbing stairs, independent living, and self-care. There were no quotas on disability imposed by the researchers, and 29% of the sample did report one or more of these disabilities, which was a total of 3,880 people. Compared to people without disabilities in this sample, people with disabilities tended to be a little bit younger. They were more diverse, meaning that they were less likely to be white, non-Hispanic, more likely to report identifying as transgender, non-binary, or other gender. And they were also more likely to report lower household income. Next slide. Okay, regarding telehealth utilization, overall, people with disabilities were more likely to have had any telehealth visits in the previous 6 months. About 66%, or 2/3, reported any telehealth visits, compared to just under half of people with disabilities reported visits. In terms of the odds ratios, when controlling for age, race, gender, household income, health insurance, and geographic region, people with disabilities were 2.3 times more likely to have had any remote care. They were 1.9 times more likely to have had any telehealth visits with their primary care provider, and 3.4 times more likely to have had any telehealth visits for mental health care. Now, note that this would of course make sense if they reported a disability that was related to a mental health condition. So a little bit more investigation into that number is warranted. So people with disabilities were also more likely than people without disabilities in all cases to say that this was more remote care than they typically had in a 6-month period, which suggests that pre-COVID, people without disabilities may have had a bit of a head start on a more gradual transition to telehealth. And also people with and without disabilities were equally likely to say that the increase in the amount of telehealth care they received was due to COVID. Around 80% said so. Next slide, please. In terms of the ways that COVID affected the increased use of telehealth, people with disabilities were more likely than people without disabilities to say that it was because of a stay-at-home order. They were equally likely to say that it was because they didn't want to go to their provider's office. And they were a bit more likely to say that they could get a remote visit sooner than an in-person visit. And almost twice as likely to say that because of COVID, they didn't have transportation to get to their provider. Next slide, please. So what was the patient's experience with the telehealth care that they received? Reporting about their most recent telehealth visit in the previous 6 months, people with disabilities were about 1.7 times more likely than people without disabilities to report that the overall quality of their visit was fair or poor. They were almost twice as likely, 1.8 times, to lack confidence in their provider, and 1.3 times more likely to say that they would not recommend telehealth in general to a friend or family member. Next, we'll look at these same outcomes for 2 different specific types of care. Next slide. For primary care visits via telehealth, people with disabilities were twice as likely to report that their primary care telehealth visit was fair or poor quality, 1.8 times more likely to lack confidence in their provider, 1.8 times more likely to say they would not recommend their provider, and 1.3 times more likely to say that they would not recommend telehealth in general. Next slide. Regarding mental health care, compared to people without disabilities, people with disabilities were no more or less likely to report the quality of their mental health telehealth visit as fair or poor, but they were 1.6 times more likely to lack confidence in their mental health provider. They were no more or less likely to say that they would recommend their mental health provider. And they were 1.5 times more likely to say that they would not recommend telehealth in general for mental health care. If I can just pause to summarize for a moment, a takeaway from these last 3 slides is that people in general were less satisfied with the telehealth that they received for mental health care than for primary care. However, there were fewer differences between people with and without disabilities regarding mental health telehealth care. Regarding primary care, people with disabilities were less satisfied and more likely to have issues with the quality of their telehealth care than people without disabilities. All right, next slide, please. Now, looking at a few of the specific items about the patient experience of care, which are important because they suggest some actionable areas for improvement that providers can do to provide more accessible telehealth care for people with disabilities. Compared to people without disabilities, people with disabilities were more than twice as likely to say that the provider did not explain things in a way they could understand, almost twice as likely to say that their provider did not listen carefully to them, 1.8 times more likely to say the provider did not show respect for what they had to say, 1.5 times more likely to say that the provider didn't make a personal connection with them, 1.6 times more likely to say the provider did not understand their health need, and 1.3 times more likely to say the provider didn't spend enough time with them. Next slide, please. Before I conclude, I'd like to note a couple limitations of this research. First of all, it's important to be aware of the typical limitations that are associated with any studies based on self-report, that is, accuracy of recall and reporting. Also, despite being national and having quotas to ensure some representativeness, internet panel research obviously doesn't reach everybody. And this is perhaps an especially salient point when talking about telehealth, as it is an online service. The purpose of this study, I will say though, was to illuminate differences in the quality of remote care experienced by people with and without disabilities who got remote care, but it does not address the digital divide that we know exists between people with and without disabilities. Next. So even among this sample, we could see some technological differences emerge. So people with disabilities, for example, were less likely than people without disabilities to use a laptop and were more likely to use a smartphone for their telehealth visits. People with disabilities were less likely to use broadband or cable internet and significantly more likely to use dial-up connection for these visits. And finally, they were twice as likely to report that the audio or video connection was fair or poor. And in conclusion, I would say this study does not include people who have no internet and couldn't get telehealth or couldn't, respond to this survey because of a lack of technology. And this is an important area in need of exploration because even though we may go back to more in-person care when the pandemic situation improves, telehealth is most certainly here to stay and will continue to expand. And it's important that people with disabilities have equitable access to good quality telehealth care. Next, thank you. And now I will turn it over to my colleague, Debra Brucker.
Allison and Kim, there are lots of questions in the Q&A box for you both. Really great stuff.
All right, thank you, Kim. I'm Debra Brucker at the University of New Hampshire's Institute on Disability, and I'm talking today about food sufficiency and barriers to free food access among working age persons with disabilities before and during the COVID-19 pandemic. This study was funded by NIDILRR as part of the STATS RRTC, and some of the work was also supported by HRSA, the Health Resources and Services Administration. And I want to thank my colleagues, Grace Stott and Kim Phillips, for their assistance with this study. So as background, we know that working age persons with disabilities are an economically vulnerable population who are more likely to live in food insecure households. They may also experience more individual or structural level barriers to accessing food. And we know from the talk yesterday, if you were online, that the US Census has been running a household pulse survey since April 2020 to try to track many things, including changes in food sufficiency for Americans during the pandemic. So the survey did include data broken out by many subpopulations, age, race, gender. It does not at the time provide any information about food sufficiency for persons with disabilities. It was good to hear yesterday that they are planning to start to include disability measures in March 2021. But our study, given this gap in information, we tacked some questions into the survey that Kim just discussed to see if we could get some information about food sufficiency in March of 2020 and in September 2020 to see what the changes were. So it's a similar survey, the same survey that Kim conducted. It collected demographic information as well as a measure of food sufficiency prior to COVID-19. So we asked people to recall back to March 2020 and within the last 7 days of when the survey was administered in September. We also collected information about receipt of free groceries or meals or the use of food programs or pantries in the past 7 days, any barriers or concerns with using these programs, and participants' confidence in affording the foods they needed over the next 4 weeks. conducted descriptive statistics and multivariate analyses to provide estimates of food sufficiency, access to sources of free food, and concerns with accessing free food. Our focal variable was disability, using the 6 questions that are standardly used in many national household surveys, as Kim reviewed. And our dependent variables that we're most interested in were food sufficiency, and it's based on a US Department of Agriculture food sufficiency screener, where people who say that they have enough of the kinds of food that they want to eat are considered to be sufficiently accessing food. We also asked during COVID, so in September 2020, whether people received any free groceries or meals or used any food programs or pantries, the sources of the free food, and concerns with accessing this free food. We also controlled for age, gender, race, ethnicity, employment, income, and whether participants or respondents were receiving supplemental nutrition assistance program benefits. So our findings in terms of food sufficiency highlight, even before COVID, and again, this is based on people's recall as of March 2020, about 65% of working age persons with disabilities met the definition of being food sufficient at that point, compared to 78% of persons without disabilities. In September, this dropped for both groups, as you would expect, and as I'm sure you saw in the news, the challenges with food insecurity as the pandemic progressed. But this was an 8 percentage point drop for people with disabilities, compared to a 5 percentage point drop for people without disabilities in terms of their levels of food sufficiency. And these numbers do adjust for age, employment, ethnicity, income, SNAP participation, race, and region. So we also asked what was the reason for food insufficiency, and you can see that some of these, are economic. So 91% of people with disabilities said that they couldn't afford the food they needed, compared to 81% of people without disabilities.
So economics matters is what you're saying, aren't you, Deb?
Not so much, because if you look below, there also were concerns about getting out of the house. People with disabilities were more concerned about getting out of the house or being afraid to go out to get food than those without disabilities. There was one difference where people without disabilities were more likely to state that they couldn't get delivery of food. We'd have to explore that more to understand perhaps people with disabilities weren't trying to get deliveries as much. And then they both had similar levels of stating that stores didn't have the food that they wanted. So we did ask, as I mentioned, whether people received any free food in the past week. And this was in September 2020, and we found that 59% of working age persons with disabilities received free food in the past week, which is really high, compared to 41% of those without disabilities, which is also quite high. And if we look at the sources of the free food that they received, we find significant differences in several areas, with people with disabilities being more likely to obtain free food from a food pantry or food bank, a shelter or soup kitchen, or other community program, compared to people without disabilities. And then high proportions of both groups said that they received free food from family, friends, or neighbors in the past week. So we also asked whether people had any concerns with accessing free food, if they did so. And you can see these kind of split up into different areas. Some are more administrative, some are more structural types of issues, some are at the individual level. So for an example, administratively, people with disabilities were more likely to be concerned about paperwork or qualifying for programs and accessing free food than others. Some were more individual perceptions or worries about stigma. So people with disabilities were more likely to state that they didn't want to rely on food programs or pantries, or worried that others would find out that they would use these programs, compared to people without disabilities. Transportation was an issue. People with disabilities noted that there was no transportation to the food program or pantry. Long lines and wait times are more a concern for people with disabilities than those without. Fewer deliveries or reduced hours due to COVID was a concern too, more likely for people with disabilities. And then at a more individual level, people with disabilities were more likely to report that they had difficulty preparing any food they obtained from the food program or pantry. So once they were able to obtain the food, preparing it at home was more of a concern. So just to reiterate the key findings, working age persons with disabilities were more likely than others to face food insufficiency, both before and during the pandemic, and to access any free food during the pandemic, and to access it from a variety of places, including food pantries or food banks, shelters or soup kitchens or other community programs, as well as family, friends, or neighbors compared to others. And to have a host of concerns with accessing that free food, some of which we could tie to easy, hopefully easy policy solutions in terms of streamlining paperwork or eligibility, but addressing some of the stigma issues around not wanting to rely on programs or worrying that others will find out that they use these programs and take a more nuanced type of approach. Transportation, seems to pop up in so many areas in disability research as a concern. So these are things we can keep in mind. Even as the pandemic ends, these will still be areas of concern for programs that are trying to provide food to this population. And I look forward, as the Household Pulse Survey includes information beginning, as I said, in March 2021, the census survey, that we can better track month to month how food sufficiency is changing for this population. So if you have any questions, you can type them in the Q&A in the webinar, or you can email me directly at debra.brucker@unh.edu. And I will pass this over to Andrew.
Thanks, Deb. All right, so Shreya and I are gonna go through employment trends, time trends, and state patterns. The state patterns is something brand new that we're looking at. Some of this data, if you've gone to the NTIDE report, which is joint with Kessler Foundation and the Association of University Centers on Disability, we have our monthly webcast the first Friday of every month, and we've been doing some special COVID-related webcasts at around the mid-month, Fridays of the mid-month. So that's the NTIDE report, NTIDE. If you just Google that, I believe you'll go straight to either Kessler or UNH. All right, so let me get started with this presentation. So we're going to look at national trends for the employment to population ratio and also the labor force participation ratio. And then we'll look at state level estimates. Looking at the trends going back to 2008, this is March. So this is the employment to population ratio. So the percentage who are employed. This age group is age 16 to 64 following the Bureau of Labor Statistics results. These are results that have come from the current population survey, which is the source of the official monthly unemployment rate for the US. So you see here the line for people with disabilities and people without disabilities. There's a large gap. You can see the Great Recession in 2008, 2009, 2010. You see people without disabilities improving around 2010-11, and a slow increase over time, eventually being above what they were in at the beginning of the Great Recession. For people without disabilities, you see a longer period of time that potentially you don't really see a true recovery until, say, 2015. And then you start seeing a period of time, this is when the economy was in full employment, where the two lines actually start getting a little bit closer together. And so this is actually March of 2019. 2020, just before the pandemic, you actually start seeing a bit of a decline in the percentage employed among people without disabilities, a slight decline that may be due to some of the international trade that was starting to be restricted at the beginning of March. All these questions were asked in the second week of the month. So I'm going to quickly go through the months of the pandemic. We see this big decline for both people with and without disabilities during the first, when we started having the national lockdown late March and April. Notice that the lines are these two the two colors, the two series are on different axes. So the 63.2% goes below where people with disabilities were. That's kind of hard to manage with the gap being so big between people with and without disabilities. We frequently have to graph them on separate axes. Here you see May, you start seeing the recovery quickly. This is not just due, this is, it's in part due to reopening, but also companies and organizations being better at, putting up plexiglass, having masks, having policies in place so that places can reopen. You can remember there was a shortage of plexiglass at this time. Oops, that's going backwards. So if we go to June, another big jump, bigger jump for people without disabilities. People with disabilities in July start slowing down. August, September, October, people with disabilities, you can kind of see just ratchet around. This is a maybe sampling variation, but also, it's over, the trend is definitely showing a slowdown for people with disabilities. In November, this is before Thanksgiving, we start already seeing a decline. California was starting to have restrictions at this point, and several areas across the country started to have greater increases in COVID, and restrictions were starting to be put in place. December, January, this is the last data that we have available. February will be available. The first February's data will be the first week of March will be available. But really what we see is a slowing down both for people with and without disabilities of the recovery. A huge hit in April when there was a shutdown and we started to learn more about COVID and a recovery, but the recovery's really slowed down. I would expect this to be the same. I mean, we had the rising cases. Cases have been declining since New Year's, the New Year's and Christmas hits. The Super Bowl has really, personally, I've known a couple parties in New Hampshire that had Super Bowl spread. I would imagine we're going to see the improvements we've seen the last few weeks push back due to the Super Bowl. But as the slow rollout of the vaccine occurs, we may see improvements as restrictions. I pay attention to the hospital rates and the death rates, and the need for more restrictions. If the UNH is already looking at the potential of slowing down things because of the potential of the increase in due to the alternative strains that are more virulent spreading in the US. Let me just put up last month, so we're still haven't recovered back to the previous January. Let me just say there is a bit of big news. And if we look at the labor force participation rate, this is the percentage of people that are not only employed, but also potentially on temporary layoff or furlough and actively looking for work. So they're still engaged in the labor market in some way. If we look at March, oops, sorry, went the wrong way. We see really that people with disabilities have stayed engaged in the labor market. relative to people without disabilities, people with disabilities have stayed much more engaged. This is good news in some sense because people are either on furlough or actively looking for work, staying engaged in the labor market. This could be not so great news because, as we know from a lot of Debra Brucker's research, that people with disabilities are more likely to live in poverty, and there may be no alternative but to look for work. There may be fewer family supports available, or other kinds of support, and that if you're in poverty, you're likely to have to continue in the labor force. You really don't have many other options. All right, so I'm going to turn it over to Shreya, who's going to talk about the state patterns. And Shreya, let me know when you want me to advance.
Okay, sure. Thanks, Andrew. So hi, I'm Shreya Paul, and I'm a project director at the Institute on Disability. And today I'll be talking about the state trends in employment, both pre-COVID and during COVID. So the indicator that we'll be talking about today is average monthly employment to population ratio for non-institutional civilians with ages 16 to 64. Our data source for this presentation is monthly current population survey, and for pre-COVID data we have from the months April 2019 to December 2019, and for during COVID we are using the months April 2020 to December 2020. So the purpose of today's presentation is to do a state-to-state comparison and make a call if a positive or negative change was detected. So you may not look at like actual estimates for each state. Next slide, please. So this slide shows us the employment to population ratio for civilians with disability 2019 versus 2020. At the first glance, you can see that the 2020 map has become lighter in color, and we can say that the employment to population ratio has definitely gone down after COVID hit, and that was pretty much expected. But let's look closely at a few states. On looking closely, you will find that for New Hampshire, Wisconsin, Colorado, Utah, and South Dakota, the color has changed significantly. It has become lighter. The employment to population ratio has changed from 41 to 50% to 31 to 40%. Similarly, for states like New Mexico, Michigan, Illinois, and Georgia, the employment rate has fallen from 31 to 40% to 20 to 30%. But for states like California, Maine, New York, and Pennsylvania, the estimates like have not varied much, and the color doesn't change from 2019 to 2020. In summary, we can say that COVID-19 has affected the employment of people with disabilities. In one of the articles that I was reading from SHRM Shrum, which was published in August, they talked about how 1 million people with disabilities had lost their jobs by August 2020. And most of these jobs were in the retail and hospitality sector. And the reason that they cited was most of these jobs are public facing, and because of the underlying conditions people with disabilities face, it's very difficult for them to, it just increases their risk for COVID-19. Next slide, please. So in this slide, I'll be doing a comparison between the employment trend for people with disabilities versus people without disabilities. So I have pasted the previous two maps here. Next slide. So the bottom two maps show us the employment to population ratio for people with disabilities in both 2019 and 2020. And as you can see, the bottom right side map changes its color from what it was in 2019. It has become lighter. So as expected, people without disabilities have faced job losses due to the COVID-19 as well. And if you compare the maps of people with disabilities and people without disabilities, disparity exists. People without disabilities have an employment rate of 60% and above. But what is striking is the disparity existing in states like Maine, Vermont, and Minnesota. There's a huge gap there. Now, let's discuss what about the gap in employment to population ratio between people without disabilities and people with disabilities. Has the gap narrowed? Has it widened? What happened due to COVID-19? And for that, we'll move on to the next slide. So this slide shows the shows the gap between the employment to population ratio for people without and with disabilities. As we can see, the map for 2020 is again lighter in color. From the first glance, we can say that the gap has narrowed, but let's not draw any conclusions now. Let's look at particular states. You will notice that Washington, California, Oregon, Nevada, and Texas, they have turned white. That means the gap has definitely narrowed. But for states like New Hampshire, Kentucky, Minnesota, and South Dakota, the colors have become darker. So the gap has widened in these states. Overall, if you look at the actual estimates, we'll be able to infer that the gap has narrowed by an average of 2%. Next slide, please. So this slide shows the difference between the employment gap between civilians without disabilities and with disabilities from 2020 when COVID hit versus 2019. A positive number here means that the gap has widened, and a negative number means the gap has narrowed. Looking closely, Oregon, Nevada, Connecticut, Delaware, significant amount, the gap has narrowed. As you can see that these states are white in color. States like Wisconsin and Maryland, the gap has widened and it stands out, denoted by the dark blue color. And for states like New Hampshire, Indiana, Illinois, the gap has widened slightly between 1 to 5%. For the bigger states like New York, Florida, and California, it has narrowed by like 0 to 4%. You may ask why this happened. The answer may lie in the COVID response policies of these states, but that is a subject of deeper research and is not a part of today's presentation. So that was all from my side. Next slide.
Okay, great. Thank you, Shreya. I'm going to turn it back to Amanda and put up the logistics slide and share the logistics slide. If you give me a second, Amanda.
Sure.
All right, so there's our speakers. All right, let me just say thank you to everybody and we'll open it up for questions. All right, so one thing to note.
So I'll try to begin with the ones that have not been answered in text. And then if there's time, we'll go back to the ones that have been answered in text.
Sure.
One that stands out is a question, is there a baseline of people with disability responses using face-to-face visits? Kim said she'd like to respond to that question live.
Oh, thank you, Amanda. Yeah, there were a couple questions in the Q&A about comparing, I think, to in-person. And so I wanted to mention that we did collect data from people who did not have those 1/3 of people who did not have any telehealth visits in the 6-month period about which we were asking. We asked them to report on their most recent in-person visit. so that we could do some comparisons there. And although I didn't share those results, what we see is that the difference between people with and without disabilities is very similar, regardless of whether they're talking about a telehealth visit or a recent in-person visit, which is interesting. So, you know, accessible, culturally competent, patient-centered, respectful care is what people with disabilities need, both in person and via telehealth. So hopefully that answers the question.
Thanks, Kim. I see there are a couple questions about whether their providers are offering and providing captioning or interpreters for patients or clients for telehealth sessions. And is HHS doing anything to make that happen? And a similar comment or question is that telehealth for persons who are deaf and use ASL and for hard of hearing people who need captions is often inaccessible. And that is something that we've seen come up a lot. I didn't know if any of the panelists had any further information from their work on the deaf population specifically.
Of course, I don't know what HHS is doing, so I can't speak to that. I apologize, but I did answer one of the questions saying I'm personally not aware of a great body of literature about deaf people's use of telehealth, although that may be forthcoming. I did want to say that in our survey, as I mentioned, we ask about hearing loss, hearing difficulty. So we could potentially look at differences by disability type as long as sample size allows. We haven't done that yet. We also did ask specific questions about the types of accommodations that people typically use for an appointment, including captioning, interpretation, like having a personal assistant there, and others. Very few people in our survey, which is probably not surprising as an online internet panel survey, very few people needed any of those accommodations or typically used them. So I don't think our survey will be a great source of answers to those questions. So yeah, thanks.
Great, thank you. Okay, Andrew and Shreya, I know we have a couple of questions for you guys. One person is asking what is defined as employment for people with disabilities within your data?
Sure. So it's whether you've worked in the past week. It doesn't refer to hours or whether there's benefits eligibility or whether it's full-time, full year. We do have the ability for some of our data sets to look at better level, more select levels of different alternative definitions of employment. That's the employment. Someone else also asked about our sample sizes. Some of the sample sizes are small, and we do average over 9-month periods. When January and February come out, when January data comes out, we'll average, it might actually be out already, we'll average in 10-month periods. Of course, once we hit April, we'll be stuck with just, we don't want to add the COVID into the pre-COVID area. So that's our approach so far. Some of the standard errors are pretty small for the smaller states, as you would expect. And even at pooling, I expect that will be the case even when it's 12 months. Someone asked, about labor force participation rate. I'll just keep running there, Amanda,
okay,
for just a minute more. Someone asked about the picture for parents and especially mothers. There have been some evidence that, I haven't looked at it by disability status, but that women, particularly when it came to September, fell out of the labor market as children started to go back to school. That's something that we definitely want to look at race, age, gender differences. Some of that work is being done at ODEP as well. Chris McLaren presented yesterday, and he may have some results by gender and parenthood. It's something we can definitely look into. You know, there's we said there's not much data, but there's actually quite a bit of data. It's hard to get it all out and make sure that we're being accurate and estimating all the standard errors correctly. The statistical inference, whether things are statistically significant, is the CPS is not the easiest data set to work with when it comes to that. I'll turn it over to you, Amanda, and so we're not looking at. Do you see any other questions?
I see a couple still for you. Are we seeing any new job accommodations with COVID for people with disabilities?
Yeah, so that's a good question. Right now, I don't know of any data that collects information on accommodations on a national level. There might be some information in the survey that Kim and Deb were referencing, but I'm not aware of any. I'd imagine there are. The Health and Retirement Survey asks about various forms of accommodation. You know, it's one of its modules but I'm not sure if that's fielded this year or not. So.
Okay, and just above that is sub-minimum wage employment included in employment?
Yes, it is. Well, it's likely to, yes. It really depends on whether how a person responds to the question or how these are answered. It's a proxy survey. It's answered by the kind of the most responsible adult in the household. It depends how people respond. It is quite possible that some view sub-minimum wage as rehabilitation, not necessarily employment. So it's possible that it may not be picked up. Yeah. I'm looking over some of the other questions. Let's see. Policy. So, you know, can this be explained by different policies? You know, right now we're trying to get a handle of just what happened, why it happened, and why there were differences is pretty interesting. Some of the information that Allison has at the state level would be interesting to look at some of the states specifically, you know, around counties and county variation in policy. Remember, there's a study out there from midsummer around mask policies in Kansas that some Kansas counties, and Kansas has a lot of counties, some Kansas counties took on mask restrictions and others did not. And there was a big change in the COVID infection rate. And studies like that are likely going to be coming out as we go forward to look at how state responses and how states responded differently. In terms of employment supports and employment support systems, it'll be interesting to see what kind of data comes out of, say, vocational rehabilitation through RSA about spending and services provided over the COVID period of time. That data is still not quite where it needs to be in order to be analyzed. Okay, so any other questions you see there, Amanda?
No, I was turning back to the ones that have been answered, but I don't. There's a question at the bottom now. Any about desire for continuing with working virtually, and desire between people with and without disabilities?
Yeah, so that's a really good question. It's an internal debate amongst us, some of the people on the call, about do we go back to work or do we start working from home? A lot of companies are looking to save on rent. Particularly places in expensive cities are really looking towards remote work. And I think that comes to a mixed bag, that work is viewed as a way of social integration, not only for people with disabilities, but for people without disabilities. And it would be a concern that people are working from home more likely. That's good in some ways. but it's a concern about social integration and the degree to which people are able to interact with people around them. So that's a really interesting question. It's also an interesting question of whether it would be available to them, you know, because some of us will be going back, you know, we've been working virtually at UNH since March, and, you know, it would be interesting to do that, to see that.
I just wanted to note that there were a number of questions about the methods that were used in the first presentation, and they have been answered in the text. So be sure to check out the answers in the question and answers if you have a question about that. And the same is true for Deb's questions as well. And then Kim, I see another question for you. The question is, you presented generally negative findings for satisfaction with telehealth. Is it possible that these results are driven by an abrupt shift to telehealth due to COVID? If perhaps the quick scale up didn't allow medical providers and or patients to adjust?
Yeah, absolutely. I mean, two things. One, I did look at the negative side, but and I didn't highlight the percentages in my talk. I said, you know, maybe that people with disabilities were 2 times more likely to say that the quality was fair or poor, but 10%, that's 10% of people with disabilities. So there's a lot that is good in what we found. You know, the majority are satisfied with their telehealth. That's people with and without. It's just that among those who aren't, people with disabilities are more represented. And yes, I think that there was a rapid switch to telehealth, and a lot of places were kind of figuring it out as they went. I know this anecdotally, you know, more than through research study, because there hasn't been a lot of time to publish a lot of that yet. But anecdotally speaking, certainly. And it's possible that if we did this study now, you know, a year into it, that the results would be different.
And did you make any comparisons to satisfaction with in-person versus telehealth?
Yes.
Among people, I can't remember that.
Yes.
That might give some indication as well.
That's right. I didn't share those findings today, but yes, they look very similar.
Yeah, I was kind of wondering if it would be, if it's similar, if they are similar to the dissatisfaction with in-person visits, you know, that it's,
right.
We know that that can be a problem in general with lack of accessibility and, you know, other barriers to quality healthcare for people with disabilities. So,
I agree. And, you know, to me, one of the key take-home points is that it doesn't matter what your modality is. Providers, there are things that providers can do to improve the person-centeredness, you know, and cultural competence of their care, to improve people with disabilities' perception of the quality of that care.
Great.
Yeah, there's a question about there's a question about the ability to disaggregate between sub-minimum wage jobs from competitive integrated employment. I've been doing some work, not with the current population survey, the samples are too small, but I've been doing some work around occupation and disability type and industry type. And I think I've come up with a way to try to identify people who are in non-integrated settings. They actually pick rehabilitation as the industry, and the occupation is one that is consistent. I've done some work in that area with the ACS, in part with the U.S. Department of Justice around the issues related to sub-minimum wage jobs and segregated employment. So if folks are interested, someday I'm just sitting on my desk now, you know, waiting to be published. So I can talk more about that at some point if anybody's interested. All right, so we're right at 1:15, it's time to end the day. We're going to try to stick around to answer some of the questions afterwards. We will be saving the Q&A. They'll be part of it'll be part of the the archive that we put up. So we'll definitely be saving the Q&A from this session. So I'm going to share my screen for one last time and say thank you to our presenters and our moderator. There's not really a good way in Zoom for everybody to clap. But I'd also like to thank NIDILRR, our funding agency, the National Institute on Disability and Independent Living and Rehabilitation Research, NIDILRR. I'd like to thank our partners, Kessler Foundation, Association of Centers on Disability, AUCD, and Mathematical Policy Research. And if you will be sending out an evaluation form at some point for folks to take a satisfaction survey and give us some suggestions about how to improve, what kind of studies people are interested in, whatnot. So with that, thank you all for all the presenters, and that's it for today. Thank you. Bye-bye.